Welcome back to our Unclenched podcast, episode number 6. Today we're going to talk with Dr. Ben Sutter about TMD treatment using DTR in the TEC scan. At the end of the podcast, we'll answer a couple questions from you guys, the listeners. But before we get started, I got to get caught up with Miss Priya. How are you doing, Priya? What's been going on? It's been a hot minute.
Yes. Well, a lot's been going on. My son started soccer. He's 5 years old, and it is the sweetest thing to watch those little boys run around. And they don't really know what they're doing, but it's really cute to watch. So that's sort of what's been going on with the kids. Just busy. I didn't realize soccer could take up so many evenings and weekend games and things like that. So that's been fun, and practice has been going well. And yeah, and so yeah, what's going on with you? What's new and exciting, Alex?
Well, what's exciting is I went to the Kentucky Derby in May here, and it was a lot of fun, a lot of mint juleps and a nice crazy hat. And that's what was fun because my daughter lives in Louisville, as you guys might know, because she goes to dental school down there, and I'm keeping my fingers crossed that I have someone entering my practice, but she has her
Lovely.
own mind, so I don't
Yeah.
know if that's going to happen, but that's what's been happening with me. And it's been fun. And any patients stick out to you, Priya?
Yes. So I had a patient named Janice who just came to me in so much pain. She had been to the ER, she had been to urgent care, she had been to multiple doctors, and nobody could really explain what was going on. She was
Hmm.
having a lot of facial pain, headaches, ear pain, neck pain. She could barely open her mouth, shooting pains through her face, shooting pains through her head. And because they couldn't figure out what was going on, she said that they sort of wrote her off as this crazy old lady. And
Sure.
yeah, it was super sad. And she wasn't even able to eat anything. She had lost a bunch of weight. She came to her new patient exam with her sister. And so after examining her, we figured out that her jaw was actually locked closed. She could barely open and she was having a ton of pain. The muscles went into spasm. And so I was the first person she came across that had an explanation as to why she was going through all of this. And so through my treatment, we've gotten her unlocked. She's not having any pain anymore. And she's gained about 5 pounds, which on her, she's tiny. So on her
Yeah.
frame, that's a lot. And so
Yeah.
she's been thrilled with treatment. She's almost done, but she's just someone that stood out to me because she's come so far, and she's
Sure.
definitely not a crazy old lady. So
Sure.
it's just,
Sure.
again, it's really amazing what we can do, and it's really not fair, I guess. I feel like we failed these people. The dental and medical communities have it by and large failed these patients that are going through something like this. And when practitioners can't figure out what's happening, they're written off, or
Oh,
they're
yeah.
written off as crazy people, as drug seekers, et cetera. And she was none of those things. She just wanted to have a good quality of life. She wanted to feel better. She wanted to be able to eat. She wanted to be able to smile, talk, et cetera, without pain. And so she really stood out to me. And that was really rewarding to see her smiling and healthy and doing
Yeah.
well.
You gave her life back for sure.
Yeah.
Well,
Yeah.
yeah. So I had a patient, and this just goes so with what we're talking about and who we're talking with. This was a DTR patient from the next state over, Ohio. And she found me actually because of our guest, Dr. Ben Sutter. He has a great Facebook page, a lot of testimonials, deals a lot with dizziness and Meniere's disease. So she told me that she noticed at the age of 14 when she got her braces off, and she's like, I think 28. So she's been dealing with this for a while. She had a couple episodes where there was loud ringing and the room would spin and she'd throw up. So she had 3 attacks in 4 years. Nobody can explain it. Then she went to college and she had 2 attacks in 5 days. Now, where she is, her
Wow.
attacks are lasting anywhere between 18 and 24 hours. There's no pattern to when it happens. She had 2 in the fall and she had 1 in January. So she was diagnosed with Meniere's disease. And She again, Holly, she's only 28, but she came to me too because she saw Ben and she's like, "Okay, this lady is a little closer than Ben who's in Oregon." And she had also a history of clenching, headaches, ear congestion, neck tension, TMJ noises, and the dizziness. And when she came to my office, she met the criteria for me being able to do DTR. So I did it. I saw her one time, then I saw her a week later, and we were hugging it out at the end of the appointment. She's like, so
Oh,
much has changed. I feel so good. And it's only 1 week out. So, and as Ben will probably explain too, it's not just one treatment and done. You got to let the body kind of settle back in,
sure,
do another adjustment or two.
sure.
And then, their appointments get further apart. But she did a testimonial for me too, so I'm
Oh,
doing what Ben had taught me, and he's just been a great mentor for me. And every time I have a question about anything, I can call Ben, I can send him photos or
I
pictures,
love
and
that.
it's really awesome to just have somebody I can count on, and it's also awesome to just give people their life back.
Oh, it's so rewarding and amazing for that patient. Well, can you tell us what DTR is? What does it stand for?
Yeah, so DTR is Disclusion Time Reduction, and I utilize the T-scan technology. So this brings us to our guest, Dr.
Yay!
Ben Sutter from Eugene, Oregon, and here he is.
Good morning, Dr. Ben. How are you?
I'm good. Thank you for having me on. I'm glad to be
Thank
here.
you for
Yeah.
coming. And Dr. Sutter, I know we're not that far from each other, so I need to meet up with you at some point. And this tech scan DTR. This is all sort of new to me. My mentor did not do this. I haven't learned it, so I'm so excited to learn from you and see how I can utilize this in my practice. But before we get into all of that, explain to us a little bit about yourself. Like, how did you get into this type of treatment? And give us a little background on your history with treating patients with TMJ, please.
Yeah, Ben, I can't do justice for everything you've done, everything you published. You're just such a scientist, gathering data, making sense of everything that happened. So give us a little bit of your background, or a lot of your background. Just let us know
Everything.
everything.
Sure, sure. So you got to go back to before dental school, really, when I look back at it. And, the older you get, you look back on your life and you think there were a lot of decision trees that I made. I made decisions to go one way instead of the other. And you look back on that, and every decision you make builds to where you are now, right? And I'm sure you guys experience this too. So prior to going to dental school, I did two undergrads at UNLV and a 2 year stint at Columbia College of Physicians and Surgeons micro department. And you might be thinking, wow, this guy's going all the way back to undergrad to answer this question. But it's important because I spent half of a decade in research, right? And so this created a lens by which I examine everything. And one of the mantras in science is like, nobody cares what you think. What is the data? And is it repeatable, right? And does data drive your treatment? So that is more important to me than any continuum you have completed. So I know a lot when dentists get together, they're like, "Oh, have you done, Cois or Spear? Have you done LVI? Oh, I studied with. I was in Jenkelson's office way back when." Um, and so, for me, the data really drives everything. So, like, my whole journey began. I bought my first practice, and I went from a large group practice to solo probably about 18 years ago. And I cut off two crowns on this woman. And she comes back to get the crowns in. And these crowns needed to be redone. They were probably 30 years old and chipped and mangled. And she grabs my hand and she's like, I need to let you know you saved my life. For the last 2 weeks, I haven't had any migraines. And I've been waking up for 20 years with migraines every morning. And you think at that point, you're like, okay, doctor needs to start paying attention to occlusion. And I really didn't like oral facial pain. I remember sitting in that course and thinking, sending all those out. I'm not going to be treating any of these patients. I don't want these patients in my practice. And so when I started looking at, well, where should I go to learn more about occlusion? Because I helped this lady so much.
Mhm.
And everyone that I talked to was like, whatever you do, go see whoever you want, but don't go to Las Vegas. Stay out of Las Vegas. So I booked the first flight and course in Las Vegas. I'm like, well, what's the big mystery,
Rebel, I
right?
like it.
Well, I mean, at some point you
Yeah,
gotta stand on your own two
totally.
feet. And like, I had no intention of being a key opinion leader or a lecturer or writing papers either, right? So I get to my Core 1 course, my first course at LVI, and they're talking about measuring muscle, and they're talking about joint sounds and jaw trajectory. And I'm like thinking to myself, I'm like, wow, this is really what being a doctor is about, is measuring function. And so I remember kind of going back and I'm like thinking, why am I hearing about this now? Like, I spent
Right.
$170,000 in dental school. No one has ever talked about this.
Exactly.
So I start pulling off all of my old occlusion books, and it's in there. Like, they reference Jenkinson in the book. And I'm like, well, it may not be on the boards, but like, shouldn't I have heard about
Yeah.
this as an option, right?
Right.
So what turns out then is I start making a lot of neuromuscular orthotics for patients. And the kind of one of the mindsets is, well, a patient may come in with some really weird, what seem to be unrelated symptoms. And so there's no harm in making an orthotic, tens them, shoot a bite, get your orthotic in there, adjust it, because the idea is if it doesn't work, you can always take it back and the patient goes back to normal, right? You haven't done anything reversible. You haven't done anything irreversible. Let me correct myself. But the longer a person is in an orthotic, that reversible, irreversible, that doesn't hold water, because the joint starts to remodel. And then all of a sudden, you'll start seeing patients that can get the front teeth together, but not the back teeth together. All right. So we have to kind of take that with a bit of a grain of salt. So at Core 7, going back to LVI, Core 1, I bought a K7 and I completed their curriculum, took the test, earned my fellowship. And the next year after starting Core 1, T-Scan entered my practice, and this was 2009, 2010, I can't remember. And at the time, it was the perfect bite doctor. This was pre-Trudenta, because that's what they developed into. And I filled in some other paradigms, including full mouth rehab and both centric relation and neuromuscular principles, with aesthetic masters and LVI. Spent some time with Mark Piper down in Florida. Took some coursework with equilibration seminars. They weren't using a T-scan at all. I earned fellowship and mastership in ICMO. I have Curtis Westerson to thank for that. He kept pushing me and would not shut up until I would do the mastership. So thank you, Curtis.
Thanks, Curtis,
And
if you're
then
watching.
he will be, and I'm sure I'll get an email later. And then then I earned fellowship with the Center of Neural Occlusion, and so that's when DTR really entered my practice. This was in 2014, and so I saw Nick Enyos treating people on YouTube.
Yes, I've seen him
and
too. Yeah.
I was astonished at how fast the results were coming, and Alex spoke to this earlier. And so I'm thinking, well, I take care of all of these symptoms too, but I can't do it in a visit or 2 or 3. It usually takes 3 or 4 months of adjustments, and patients, I generally got the feedback that patients were happy with the results. the problem with the neuromuscular orthotic is it's based on patient compliance. So, like for me, I lived in an orthotic for a decade, and Bill Dickerson shot the bite, and Bill Wade built the orthotic. So there's no more competent person to do those two
Yeah.
things in the neuromuscular world, right? And so what happened was I would spend probably a month or two in the orthotic three or four times a year, right? I didn't have to wear it all the time, but I'm not going to wear it as long as I feel good. And the moment I don't start feeling good, I'm going to wear
Yeah.
it. So there got to be a time where I had to put my money where my mouth is because the orthotic wasn't working anymore. And all of my scans looked good. And I'm like, okay, so here I am, a treating physician of oral facial pain, TMD, whatever, and I'm suffering, man. I'm living my work. So I called my mentor.
Can I interrupt for just a sec, Dr. Ben? Could you tell us what your
Sure.
symptoms were? What were you suffering?
Yeah.
Sorry.
Symptoms were neck pain, shoulder pain, facial tension, headaches. I didn't really have any migraines, but thank God I didn't have dizziness, didn't have any vertigo. Tinnitus was really random, but it was mild. And it would only last for like 10, 15 seconds, and then it was gone. And then the last thing was, I think, a sense of globus, or almost like a hand resting on the neck. Like I wasn't really choking, but like just swallowing water, swallowing your own saliva was a challenge. It didn't affect speech. So while I was suffering, I could still work, oddly enough. And then you'd go to clear your throat and you kind of get behind the patient and wince while you swallow. and then I flew Robert out. I'm like, dude, you've got to treat me. He's like, yeah, what's going on? So he came out, and the first treatment, I really didn't have this holy cow effect. I kind of felt like, okay, well, my bite feels better, but like there isn't this instantaneous thing. And so I kind of felt cheated, right? Like you've done this for so many people. Personally, I think I should get a pass, but that's not how life works.
Yeah.
So, the second revision, I was having a lot of neck and headache type pain. And so Alex already spoke to this, that it's not one and done. And so I flew Robert back out, and I had another adjustment with him. And that's when I felt the immediate release.
Wow.
And it was like he adjusted 2 teeth. He wasn't even done with the whole adjustment. And he removed the handpiece out of my mouth, and I closed down just to relax while he was doing something else. And I'm like, oh my God, that's what that was.
Yeah.
Wow. And who is Robert? Sorry.
That's okay.
Robert Kirstein, he is the developer of DTR, and that whole story has its own. In fact, you guys should podcast him,
Sure,
and ask him about, like, when did you first notice the effect could be instantaneous, because he tells a really cool story about that.
Yeah.
But so since then, I've kind of once I started doing DTR, I realized that, like, okay, I had the K7, but DTR requires to be linked in real time with a bio EMG.
Mhm.
So to do it, I'm like, I had the first question I had was, do I really have to go out and buy
Right.
another pack, right? And the answer is yes. And you want to, because it's so fun, it's so exciting to get these results so fast, because you're dealing at the level of the neurology. And most of our TMD, TMJ concepts are biomechanical. They're not neurophysiologic. Excuse me. It's early here. And so then what transpires is you're like, okay, I'm using this. And the guys that are using the bio EMGs are talking JVA. They're not talking joint sonography. So you're like, okay, well, I got to do it. I got to buy the JVA. The next thing you know, I have the whole biopack with mastication. And, you can't complete DTR with the K7 or an Occlusense. And that's not a dig on those technologies. That's just a fact, right?
Right.
So different technologies are going to have strengths and weaknesses, and you can't measure force and you can't measure time with either of those two. Um, so, and I think there are some myths out there that are holding us back, and most humans want to validate what they're doing. So instead of thinking for themselves, they judge what others are doing. So, and it's not unique to dentistry, and a lot of people aren't ready to make that leap. In fact, this last little bit answers the question, but um, when I was transitioning from being a TENS neuromuscular traditional dentist over to doing, like, man, I'm leaving neuromuscular dentistry, and this is very uncomfortable for me because this is what I've been doing for so long. And the CR docs aren't going to come to the rescue, right? You think it's going to be the neuromuscular dentists that are going to say, you know what, this is another form of biometrics. I need this. I want this. And what I've found is neuromuscular docs are just as dogmatic about NMD as the CR docs are about CR. And it's like, wait, we have all these possibilities. And so as a physician, you have to pick and choose. And so when the whole purpose of telling you what I did before I got to this point was I would take these paradigms back to the office, and I would run a JVA. I would throw them on the EMG. I would give them gum to chew and measure it. And you're like, some of these you can't do. Like an NTI is a great acute diagnostic thing that we can do to stop clenching and bruxing. You put it in, the patient says, I feel better. And you're like, okay, I think I know what's going on, right? But you can't do mastication with that, right? And if you leave it in long term, you're going to see teeth intruded because the clenching mechanism hasn't stopped. You just separated the teeth. So at least, wouldn't see that in everyone. But anyway, did I answer the question? We kind of went
Yeah,
on.
yeah,
Oh, I
that's
love
okay.
it.
We're always going down a little tangent.
Yeah.
It's no big deal. But I met Ben, Priya, I don't know if you know this, but I met Ben at ICCMO, and that is where he was lecturing. And I had a T scan, but I wasn't utilizing it to the capacity, and I didn't have the knowledge. What I was utilizing was post ortho just to balance the bite, make sure the same tooth was on one side as the other side. So after I met him at ICMO, and I had the girls at my office with me, they're like, you know what? We need Ben. So then I went first, I think, to a class in Dallas because I thought, okay, took my ladies with me, and or it was Houston, I think. So anyway, we sat through the class there, and then we saw Ben and Robert lecture, and then when I'm like, son of a gun, I gotta learn this.
Yeah.
So
Yeah.
then Ben came out to my office, and
Nice.
he taught me. And then after that, I did have Robert come out to my office, and then
Nice.
I did get DTR certified, which, Ben, thank you for that certificate. It will be hanging in my office next week. That's on my agenda to check off this weekend.
Oh my
But it was
gosh.
just fascinating. It was
Well,
literally mind-blowing.
when did you have Dr. Ben fly out? When did you have Robert? When did you have them? When did this happen?
So this happened probably, like, I don't know, Ben, maybe 2 years ago or so. Ben came out.
I think it was 21 or 22.
Okay.
Yeah.
Yeah. He came out, then I utilized what he was doing. And in the process, Priya, the amount of help I had understanding with texts or emails, and then I had Robert come out to, like, kind of snap things together a little bit more. And then I had to take a test also. And then that's how I got certified. But the two of them are just, if any dentists are listening, and even if you're an orthodontist, because they use this post ortho, every patient, no choice, we do it. That's just part of their treatment. But you got to look up Dr. Ben Sutter. You got to see what greatness he's doing.
I love this.
It's great.
Dr. Ben, I didn't know any of this. Like, I met you briefly at, I think, the myoliner conference, and I've met you a few times, but I didn't
Yeah,
know any of this. So I feel like I've just been sitting in this little bubble without any knowledge of anything. And so now I'm totally going to be contacting you.
Oh,
And
he's gonna burst
hopefully,
your
sure,
bubble.
sure.
He will
yeah,
burst
I
it.
want that bubble burst. I need it. And so if you're open to it, I would love to have you come to my office too. But anyways, we can talk about that later. And this is just
Sure.
fascinating to me. And so Dr. Ben, we're all about the joint. And I think we all agree that when the joint is positioned back, like that traditional CR, up and back, a lot of problems start, like pain, headaches, ear issues, etc. So I guess my question too, and this is not just for the viewers, because I'm learning a lot in this episode. So thank you, Dr. Ben, and thanks, Dr. Alex, for bringing him on. And how can adjusting the bite or the teeth bring the joint forward? Like, can you explain it a little bit more for me and for the viewers? What is disclusion time reduction? Like, yeah.
Sure. Well, a point of clarification. I wouldn't say that I'm all about the joint. Okay. The joint is absolutely important, and I don't want to, um, disparage anybody from, looking at the joint, because it's important that we need to assess function as well as structural integrity on these TMD patients. But there's about 48 different symptoms that fall under that TMD umbrella, and many different diagnoses, right? Probably just as many different diagnoses. And so, a cone beam, a CBCT cone beam, and joint vibration analysis. So you actually have numbers and you have quantification of what those numbers are before we start doing anything. And I think as far as lining up what a patient's options are, um, you need to disclose all the risks and benefits and limitations of each one, because they don't all work the same, right? And so the patient needs to understand what the doctor has to work with, and then assumes risk based on choice. All right. And it doesn't matter if you're talking TMD, you're talking, I'm going to get a laparoscopic appendix versus traditional incision, right? So, for example, if a dentist has ortho, or if a patient has ortho 4 times, and they're still having a problem, and they have the orthodontics to move the teeth into the correct position and take into effect the joint and all the muscles and everything, and they still have the same problem, ortho is probably not going to be my top choice to treat this patient, right? I
Right.
mean, like, what am I going to do different that the previous 4 doctors didn't do? And so, how does adjusting the teeth allow the muscles to relax? That's huge. And so, the interesting thing about the teeth is they are one of only 2 known peripheral nerves that come from the PDL that go directly into the central nervous system.
Mm.
They do not synapse. So, what does that mean? Well, it means each tooth has 1 million periodontal receptors, right? And you have all this data going right into the central nervous system. And where is the first synapse? It's in the muscles, it's in the trigeminal motor nucleus. The next branch of that nerve goes right to the muscles. So, if you can dial down
Mhm.
the amount of input going into the trigeminal motor nucleus, you can essentially, um, I don't want to say turn off the muscles, but kind of turn off hyperactivity. And I can actually show you guys
Yeah.
that. Let me see if I'll show you an
Cool.
example. Okay. So, we're going to get back into the question about, hey, how does adjusting teeth affect muscle hyperactivity? So, what I'm going to show you is Renee, and I made a comment about ortho being done 4 times, and this is Renee. She's been suffering with migraines for 20 years. Okay, and she's a general dentist, and my heart breaks for her, because I mean, like, this is like being a Marine and leaving a brother behind, right? You wouldn't do it. You risk your life to bring that Marine home. Well, she's one of us. She's a dentist, and she has been suffering for a long time. And you guys already know what's the stick. She's crazy. She's a woman. She's needs to de-stress her life, and
Right. Good luck.
she's a business owner, and she's a mom, and she's a wife, and she's struggling. And so here you're seeing a split screen of um, uh, T scan being on the left side of the screen and your EMGs being on the right side of the screen. Okay. And if you look on the right side, it's divided in half. You have the upper level and you have the lower level. Okay. The upper level, what you see is the red blotchiness. That's the muscle burst from the temporalis, and the green blotchiness, that amplitude, is the masseter muscles. And so there's not a lot going on. Actually, there is a lot going on. There's a lot of background going on. And then she bites, and all these muscles fire, and then she makes a movement at C, and these muscles still remain hyperactive, right? Even after the movement is stopped. Okay. And it looks like she's firing at this particular position after the C line 361, 350 microvolts. I can't read that. It's too small. All right. So you adjust the bite, and then you look at how the muscles are behaving, right? So you don't have to be a dentist to appreciate that the amplitude of those four muscles has gone down, right? And it hasn't gone down a little bit. The microvolts reading here are 35. So we went from 361 to
Wow.
35. That is an order of magnitude difference,
Yeah, sure.
right? That's massive.
In
So,
seconds.
and we did this live. We did this. I did this in Seattle. She was hurting. She attended a different course that I had. I actually treated one of her patients, and her patient's like, "We suffer from the same thing. You got to go see this guy talk." So she did, and we used her as a patient in one of the DTR courses. And it's at the end of the day, right? Everybody's getting ready to go out and eat dinner and go get drinks and relax before we do day 2. And she comes over to me and she's like, "I'm so tired. Like, I just want to take a sleep. I want to go take a nap. But I'm going to be up all night." I'm like, "Just go sleep, and don't set an alarm. You might sleep until the morning." Because the cascade of muscle relaxation, it can affect the whole body. It's all connected.
Sure.
So she comes back the next morning and she's like, "I had the best sleep I've had in a really, really long time." So anyway, the mechanism for this is the compressibility of the PDL firing into the trigeminal motor nucleus, which creates hyperactivity. So when you're doing the adjustments and you're balancing that bite out, and you're reducing the interferences and reducing the time, all of a sudden the neurology calms down. And not everyone has this immediate effect, right? Other people need days, weeks. Some people need 2 or 3 months. And you don't know who that person is. They don't know how they are. And it's multifactorial. So what are my comorbidities? What medications am I on? How old am I? How long has this been affecting me? What are my genetics? There's so many
Right.
layers to this thing that it's not just about teeth, although the teeth are the primary etiology, and anything you stick in between the teeth is going to buffer the neurology. But as soon as that comes out for any period of time, what do we see? We see people's symptoms start ramping back up, right? So there you go. That's how that mechanism works.
So cool.
So Ben, what is your typical patient? Like, someone calls your office, why do they look for you? How do they find you? Or, like the front desk answers, "Oh, we got another one of these calls." What's typical for you?
It's getting nastier and nastier, really. The diagnoses are more like Meniere's disease and trigeminal neuralgia. And that seems to really drive. The locals come because of TMD or migraines or, whatever the other symptomology is. But I think that answer has many factors as well, because the biggest part of that answer is going to be, I think patients are wanting more. So the fact that I'm actively promoting biometrics of every kind I can get my hand on and publishing with like what
Yeah.
those results are.
That's
By the
awesome.
way, just to mention that, anyone listening to this who wants to read more about DTR or the trigeminal neuralgia treatment or Meniere's disease, you can go to ResearchGate. It's kind of like a Facebook for researchers, and you create, it's free. You can create an account and you can go in there, and everything that I've published is there. Most of what Robert has published is there. Most of what Radke has published is there. So, and it's all open access. You don't have to pay anything.
So
So
what's it called
there's
again?
no reason.
What's it?
ResearchGate.
ResearchGate. Okay.
Yeah.
Okay.
So going back to what kind of patients call my office, they're usually patients who will come in and say, "Oh, all the videos," or they may have one patient, like I'm just going to pick a name, Steve. They'll come in and say, "I'm Steve." Like all of the Steve symptoms I have, and so I just figured Steve got better. Maybe it's worth trying this out and seeing if I get better too. And so I think another factor that is a driving force is, well, what is DTR, right? We kind of went over this. It's micro adjustments to balance out the occlusion and affect neurology. Okay, so when you're doing this, um, there's no, people are getting better. People are coming off medications.
Yeah.
There's no TENS. There's no surgery. There's no injections. There's no medications. There's no Botox.
So cool.
And so, when you hear all that, you're like, this sounds like voodoo, right?
Mhm.
How can this be a thing and not nobody know about it? And medicine and dentistry are always going through corrections. And we see a study, we do a study, we have another piece of the pie, and then that gives us more questions to ask. And so I think we all have a responsibility to publish those findings. And Alex, you're a great one to speak to this point where you're like, hey, I've been doing really well, right?
Right.
And I appreciate my neuromuscular training. I don't have any beef with anybody about what I was taught, because it elevated you again.
Sure.
And so, but there were cases, and we dealt with some of these cases that, man, you're smart and you're talented,
Thanks.
and you were struggling with some of these patients.
Mhm.
And so, like, what am I missing? I'm just
Yeah.
banging my head up
Right.
Yeah.
the wall. So, and then I come in, and I remember this like it was yesterday. It was so funny because you wanted more information with T-scan. I brought my EMGs because I know you're an ECMO lady.
Yes.
And so I thought, I want her to see how powerful this is. And like on your first patient, you're like, oh my God, look at what the muscles are doing. I'm like, yeah, how can that be? Because we didn't TENS her. And you
Right.
flipped me off. But it was a moment where you're like, holy shit, I'm totally seeing what this guy is seeing, right?
Mhm.
And then 5 patients later, you're like, I have to rethink some things.
Yeah.
And that's the beauty of the practice of, right?
Right.
Yeah.
So, and the single biggest question I get from these patients that are seeking me out is, oh, this technology must be new. No, it's been around for over 30 years.
Yeah.
And the patient's confused and like, well, how much does this cost? And you're like, well, depending on time of year and what their sales are doing,
Sure.
anywhere from $10,000 to $12,000. And their response is, that's it.
Mm-hmm.
Like, this is a dental office. We know it's more expensive to go to the dentist or create a dentist than it is a medical doctor. why aren't people buying this? Why is there no value? And it comes back to, well, a statement I get in trouble for saying is, dentistry doesn't care about function. You know, what is the ultimate function? It's chewing food.
Yeah.
All of you that are listening that have been to dentists over the years, how many have strapped you into the chair, hooked you up to equipment, given you gum to chew, and evaluate how well you chew? The answer is going to be very, very little.
Right.
Yeah.
And as 3 dentists who were trained in medical school or dental school, if I ask you, well, what was the extent of your education on mastication? It's going to be 0. We didn't learn that. We learned how to fix stuff and get people out of pain and, restore missing teeth and those kinds of things. Physiology was not at the top
No.
of our learning experience. So, and patients get angry when I tell them that. They're like, well, how come my doctor doesn't know this? And I'm like, well, go back and ask them. Like, I don't know what
Right.
maybe
Totally.
knew or didn't know or whatever. But we have to, temper a little grace around this too, because and some common sense. And the grace I mean is, I'm not the guy to drop an implant. I'm not a guy to do a molar root canal. I don't care about those things. And so I think the public has this idea that a dentist is a dentist is a dentist, and that's just not true.
Right.
We all have different passions.
Yeah.
We have, and I refer my endo out 100%
me
because I don't want
too.
to do them. I haven't done one in 13 years.
Yeah.
But there are guys that salivate over the next, 5 canal root canal coming in the door
Salivate.
on a second molar, and you're like, I can't wait to get into that. And you're like, have at it, brother.
Yeah. Get crazy.
And the other thing is that we have to be careful is, I like to play the guitar, right? And I've played for off and on for a long time. And loved Eddie Van Halen. Very sad that man is gone. And I wanted to sound like that guy. And so I can buy his guitar, but that doesn't mean I can play it like he plays it, right? And so that just means you wrote a check. And now I'm 53, I can afford an Eddie Van Halen guitar where I couldn't when I was 17.
Yeah.
That's great. But you need to spend the time to become proficient with the tool, because even though you had his guitar, Alex, you didn't have a coach.
Right.
And now you got 2, right?
Right.
So you're playing the instrument differently than you did previously.
Oh, yeah.
So
Right.
I just want to tell, there's been a couple of instances where, people have called TechScan and said, oh, where's their DTR doctor? And that's why we created the database, because a patient would, because whoever answered the phone would be like, oh, well, there's somebody, 3 blocks over from where you live, and they have a T-scan. And the patient would go in and be expecting DTR, and they're like, wait a minute, there's no leads. You're not putting the electric ditties on.
Right.
The dentist is like, what are you talking about? Like, I don't know what this is. So that's why we created the database. So when you go there, patients know, okay, there's a minimum level of competency with these providers. Now, I don't know how many cases these providers have done or how long they've been doing it. Well, I do know how long they've been doing it, but what percentage of their practice involves doing this specific thing? There's no way to know that. But I would say that the doctors that spent the time and the money to learn it are probably, you wouldn't spend that kind of effort and money to not use it.
Right. Exactly. Well, question, would you say that, I think I know the answer to this, but can all TMD patients be helped by DTR? And like, if not, what would make you say I can or I cannot use DTR in your case to a patient?
Sure. Well, it's how the teeth come together is what you got to look at. And I would caution that all therapies work some of the time. None of them work 100% of the time. But let's go over what are the options for patients when it comes to this, right? And we have to remember that one of the options is to do nothing, which really, I mean, it's an option. It's not a treatment option,
Right.
but it's an option. The attorneys make us say that because no one dies from, TMD. So do nothing, right? You can do a full mouth rehab where you crown and veneer all the teeth to build the perfect bite. Okay. You can do ortho, and that allows us to move teeth into a better position, right? Joint surgery. And I think you guys and Mac talked about this last week. And what's the success rate of joint surgery at 1 year?
Not very good.
Low.
Not very good. It's like
Mhm.
40-50%, right?
Yeah.
So unless the joint is gone completely, like I don't know that that would be my first or my second choice. We can do acrylic, which would be an NTI, an orthotic, a night guard, or something that's creating a barrier from keeping those teeth to come together, right? Or we can do DTR, which is micro adjustments. Now, interestingly enough, out of all of those things that I just gave you, there's only one that has been proven to improve human chewing, human mastication, and that's the last one. So, patients that are like, "Oh, I can't eat a steak anymore because I started and I love steak, but I just get so tired and I can't finish it, and so I'm horking down like chunks of meat and cutting them up small because I can't really chew." And that changes. And the funny thing is somebody who undergoes this would come in and say, "Oh my God, my wife made the best steak last night. She, pulled out all the stops." And I'm like, "Yo, how long you been married?" She's making the steak the same way she's always made the steak.
Right.
The difference is you're chewing better
Yeah.
and you can get more juice and flavor
Enjoy
after you
it.
stick it in your mouth,
Sure.
right? Yeah, for sure. So the big thing is, and this might not mean a lot to your patient listeners, but if you are class 2, DTR is not a first choice for you because you can't get anterior guidance. Now you can use the mesial of the first premolars, and you get about 80% of the effect, and that would help. But if it's a serious class 2, yeah, I'm building an orthotic, or sending the patient to do ortho first, and then coming back and doing the DTR. Class 1, class 3, unilateral class 3. That's me. I got a unilateral crossbite. DTR is going to work.
So then a bilateral crossbite's not good?
No, a bilateral crossbite, a DTR will be effective on it.
Okay.
Will be.
Then
Will be.
Yeah.
So
Yeah.
what you'll have is on one side, you'll make all the adjustments that, you learn in the class.
Mhm.
And then on the side that's the crossbite, the adjustments are just going to be mirrored.
Okay.
Right. So
Got it.
what about what's the joint have to look like?
Right. Well, it's interesting because I don't think that there is a right answer for that.
Ah,
But let's qualify that a little bit because in part of your assessment with the patient, they need to become aware of what the joint status is. So
Right.
you might be compromised right out of the gate. Like
Right.
you're a Piper 4B, okay? Like that's not the same hill to climb as a Piper 2 or a Piper 1,
okay.
right? They're two totally different animals. And so, there's Nick will always say, "Oh, you can't do these Piper classifications." In
Mhm.
fact, he's published on that. And it's interesting because you read what he wrote and you're like, but wait a minute, you did 3 of the exact classifications you're not supposed to do DTR on, and you had a good effect, right? So the stability has a lot to do with it. So what's more important than I think, and there's some people that'll say, "Oh, you should have an MRI on the joint every single time you do video, change the video, or you're gonna build something or correct something." And I don't hold that that's true for a number of different reasons. But the interesting thing for me is I want to know more about how that joint functions. So that's more important than the position of the disc. Okay, so if a patient comes in and their joints may not be ideal, meaning like they've got wear and tear on the condyle, first of all, everybody coming to see us has got wear and tear on the
Mhm.
condyle,
Mhm.
right? No
Everyone.
one comes in with like perfect condyles.
Yeah.
But if they can open 45, 50 millimeters, you're like, wait a minute, the problem's not in range of motion.
Right.
And I don't subscribe to that what is it, the retrodiscal tissue is innervated full of nerves. Because when I spent time with Mark Piper, he was like, dude, where do you think I put all my fat grafts? In the retrodiscal tissue. If that was fully innervated, those patients would be in immense pain. He's like, I'm not observing that.
Mm.
And while I don't do that procedure, I'm like, there's another thing, right? That
Interesting.
and everybody just can, spout from memory, but I don't know that it holds water.
Sure.
So I know you were trained neuromuscularly. We went through the LVI thing and all of that. And I know you got a lot of tools in your toolbox. But and I know this is a little controversial, but do you consider DTR to be neuromuscular without doing the tens that they, say in order to be neuromuscular, you have to tens?
Who is they, Alex?
The powers that be
Hey,
that
right,
are
right.
older than me. They're all older than me. I can say that.
Sure. So, yeah, there are going to be people that hold to the old guard and be a purist. And I think if Jankelson heard that, he would vomit
Ah,
because Jankelson was a pioneer. And I
Mhm.
think if you gave him a T scan and you showed him the same stuff, he would take it in a totally different direction.
Mhm.
Right. And I think that there is homage to be paid. And even look at Pankey, look at Dawson, you look at
Mhm.
these names, and they've certainly made dentistry better
Sure.
because they got hung up on a sticking point. Like, look, it's one thing,
right.
it's a big thing, but overall, was dentistry improved by a lot of people going and learning more about dentistry? And the answer is unequivocally yes. So, to answer your question specifically, this seems to be a sticking point, and if you were part of that thread, you know
Yeah.
where I stand. But I'll tell your listeners if and this came up when I did my thesis for the ICMO mastership, because I treated a Meniere's patient, and I got him. I kind of got him in a gotcha moment, right? Because I documented everything on this case with the K7. And so Meniere's patient comes in, we test her. I'm using T-scan and EMGs, but I'm confirming everything with the Myotronics K7.
Okay.
And so what happens is Norm Thomas says, well, this is a TENS-based institution, a TENS-based college. And I'm like, okay, because I thought it was a neuromuscular
Right.
organization. And so it's me versus five, and that's how you defend typically your mastership. And so, and it gets real quiet on the other end of the phone. And I say, I specifically use the Myotronics gear so you guys would understand the scans because there's a lot of similarities between how the data reads and presents with the Myotronics versus the bioresearch. But if you don't own the bioresearch, you're looking at whatever, you have no idea you don't have no idea to read this, right? So we get to the one question. I'm like, well, the patient said they were better. Plus, look at all the data. Like the EMGs on the left side, which was the affected side, have gone down and the joints are quieter. And look at the trajectory. The range of motion is different. And I'm like, either I did what I said I did, or the technology is faulty and it's unreliable.
Wow.
Well, I didn't like that answer,
Wow.
right? So I think I was the first one that got the mastership without using a TENS machine. Maybe there were some sleep studies and stuff that
Yeah.
were used, but I mean, as far as actually treating TMD symptoms.
Wow.
So I think if you are doing anything that affects how the nerves work, which ultimately translates to muscle physiology or any of the metrics that we use, it would be considered neuromuscular.
I agree.
It's not TENS based,
Mm-hmm.
but you have to
Yeah.
be inclusive if neuromuscular is going to be part of your mantra.
Yeah.
Right.
If it's not, then just take out neuromuscular and just put TENS.
Right.
And then you
Agreed.
could not be as inclusive.
So
Yeah.
so do you use the TENS then? Like, do you use that for your orthotic patients, and then for the DTR, you generally don't?
Yeah, that's
Okay.
a good question. So DTR does not require TENS
Okay.
to relax muscles.
Okay.
I've already shown
Yeah.
that. But I do use it in patients that require me to make an orthotic. But I'm still going to do the case finishing of the orthotic
With
with DTR
yeah.
principles and making sure that's balanced.
Hmm.
Because here's an interesting thing. So I pulled in a couple of let's just look at this guy, right? So this is not a neuromuscular orthotic, but this guy comes in, and the EMGs look pretty good. The blue dots across the arch look pretty good. They look about even in number and about even in size, and you would look at this and not being biometrically inclined, a traditional dentist would say, "Oh, this looks balanced." The reality is it's off 60-40. And so it's common, when a patient comes in and they've got a whole bag of these and
Yeah.
things, and they say, "Well, I went to my general dentist, made me one, and then and it didn't work, so they remade it, and then that didn't work, and then I went to a specialist and I spent a lot of money, and you know it didn't work. It made it actually even worse." Well, when you actually look at what the patient is, if the patient is like 60-40 to begin with, and you put the orthotic or the guard in or whatever, and now it's 80-20 in the same direction, you'd be like, yeah, well, that would make you worse,
Mm-hmm.
right?
Mm-hmm.
So these blue dots lie, and they lie to the tune of
Mhm.
about 13% accuracy.
Wow.
Now,
And that's what every
that,
dentist uses, the blue dots.
yeah, and if you want, dentistry loves to use this evidence-based dentistry whenever they're talking about science, and here it is right here. Uh, you don't have to believe me. Here are the publications. Go look it up yourself. I've given you all the citations when these were published, and here are the percentage of how correct dentists have been. And it's not even a 50%. It's all failing. So what does this mean for the patient? This means if the patient goes to Alex and Alex uses the tap, tap, tap paper, she's going to make different adjustments than Priya would looking at the same dots. And if they come to my office and I tap, 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 and I don't have the biometrics, I'm going to make different adjustments than the other two. And then the next thing you know, this patient's been adjusted 5 or 6 different times by something that's, 40 or 13% accurate. And if we're talking about implants, well, okay, Priya, go ahead. You can buy these implants and they'll last 12% of the time. You would laugh the rep right out of your office, right? But somehow this is acceptable, and we don't need this. By the way, this shut up a lot of prosthodontists. The some Indian researchers actually had tested prosthodontists with 2 different thicknesses of bite paper. And one was 100 microns and the other one was 40 microns. At 100 microns, they were 17% accurate. At 40 microns, none of them were accurate.
Whoa. Hmm.
Ah.
So,
Telling.
what does this mean for patients who are listening to this and they're like, man, how many times has my orthotic been
Yeah.
adjusted and not
Right.
by what?
Right.
So, you know, um, there's a lot to unravel
Sure.
Sure.
here, but I appreciate the opportunity. I want to see if there's, oh, Wait.
Wait, I like the rat study. I saw that there too. That was a neat one.
Yeah, that was. Well, we can go into that. The posture.
Uh-huh.
I got
Oh,
so
yeah.
every neuromuscular dentist knows this study,
Yeah.
right? And so I started, just looking at posture in patients, and how does forward head posture affected by what it is that we do, or the shoulders, the cant. Because if you look at this guy's shoulders in the second frame, the shoulders are off just like the pelvis. And then once the bite's been corrected, his shoulders are more in line and
Mhm.
his hips are more in line, right?
Yep.
So you can actually do the same studies. This is Cassidy, and you'll see the green line comes straight up from her ankle in both of these, right? And here the tragus of the ear is farther forward
Mhm.
pre-DTR than post-DTR. And what I want you to appreciate is the date is the same, the time is different, right? So this
Yeah.
is day one, no
Wow.
tensing, just getting the bite correct, right?
Yeah.
And then similarly, like this isn't even my case. All right. This I was asked to go into South Bend and train a couple of ladies, and this is the one of their assistants. And
Wow.
you'll see that the shoulders are canted, and even look how far to your left that her midline is off. This is the
Wow.
same
Yeah.
day, right?
She's
So
totally leaning.
this
Yeah.
stuff, yeah, she's totally leaning. And
Yeah.
so this stuff can't be taught. I'm not some wizard. I learned from Robert, and over the course of the last 10 years, I've been taking DTR in a different, direction as far as Meniere's and trigeminal neuralgia type diagnoses are going. But I don't think either of those diagnoses is what we think it is.
Wow. That is, I mean, wow.
Right. Proof's in the pudding, like they
Yeah.
say, you can't fight that. But when you were in my office, Ben, there was a patient that had cold sensitivity on a tooth, and even at that specific time, you blew air, you did cold water, what have you, but then after I assisted them, I adjusted them with your assistance, um, the sensitivity went away, like, immediately,
Wow.
just like the
Wow.
posture straightens up immediately. So what does the body go through? What changes is happening to have such a quick, immediate change, especially like on we always have patients that my teeth are sensitive to cold, or I can't bite on this side. So what's the science behind that? What's our body doing?
Yeah, that's tough answer. Because there's a whole chapter in the books that are dedicated to that question, right? But I'll put it in very simple terms. Okay. If you have interferences in the bite, and it usually happens that the same tooth is an interference going to the left, going to the right. It's usually overloaded, and it's the first tooth that touches, right?
Mhm.
So there's a lot of boxes that are checked for this tooth or even teeth.
Mhm.
And what happens is tooth on tooth friction just keeps that nerve excited,
Mhm.
okay? And then all of a sudden, you take away the offending friction by reducing disclusion time, and the nerve calms down. Now,
It's so quick.
well, I mean, it's quick in a lot of cases, but I'll tell you a story that there was a guy that Robert treated, and he's pretty close to me. And every once in a while, we'd have a conversation. And he calls me up, and he's like, "Oh my God, I'm so disappointed." I'm like, "Why? What's going on?" He goes, "Well, my daughter is in college, and she came home, and she's complaining about tooth sensitivity, and so I did DTR on it. She had obvious huge discrepancies." And I teased him. I'm like, "Oh, who did the ortho?" And he's like, "Yeah, I did." And I'm like, "Okay." So I'm like, "Did you correct it?" And he's like, "Yeah." And I gave her the ice water before and after, and her teeth were still sensitive.
Mhm.
And I was dumbfounded. I was heartbroken. And he said, "Yeah, about 2 or 3 weeks goes by, and she gives me a call, and at the end of the conversation, she's like, "Oh yeah, Dad, by the way, I had ice cream yesterday and it didn't hurt and I was able to eat ice cream." So the time that it takes for stuff to
Re-
correct is resultant of all of those factors, those comorbidities, the
Sure.
genetics, chronicity that we already talked about.
hmm
And so the patient doesn't know which one they are, and of course
hmm
we don't either. The only way to know is to do it.
hmm
Wow. Well, what about neck issues, Dr. Ben? A lot of my patients have neck issues. The small tooth adjustments, the micro adjustments that you're doing, do you see that helping the neck too? And it sounds like it may have for you as well.
Well, it did for me.
Wow.
And yeah, so looking at both of these slides, for sure,
Yeah. Look
we
at that.
do know that a forward head posture makes the perception of the head heavier, and it's not it's not a linear correction, it's a logarithmic. So that you go out 1 inch, it feels like 10 pounds. You go out 2 inches, it's 75 pounds.
Sure.
So it gets heavy real quick. And so, yeah, it does. It does. It has a profound effect. In fact, this is something that we published too. Along in the same lines of this study, we looked at foot sway and postural balance. Those things are affected too.
Sure. Sure. Look at that. Wow.
Yeah, yeah. So when we talk about sleep and TMD and the connection there, and we know there's the relationship, and a lot of times after I do DTR, patients are like, "Oh my gosh." Like your patient, the dentist said, I had the best sleep of my life, or I'm sleeping much better. Do you ever order again sleep studies if they've had them just to prove it? Or do you just go on like, well, they're feeling better, they're feeling well rested, and we'll just leave it at that?
Okay, so a patient comes into my practice and we do an Epworth screening
Okay.
on the patient. And yeah, if they are, I think the threshold is a score of 10 or higher, they should be referred for a sleep study. And of course, we see a correlation, but I don't think causation is a bit strong. And you come back to this question, we're like, I'm observing the same thing as you are. Like patients are saying, wow, I had this done and I sleep really, really well. I'm not getting up as many times. And I think part of it is, well, you're not running a marathon with your face while you're trying to relax and recover and sleep. And so the whole obstructive sleep apnea, the clenching and grounding is an arousal mechanism to
hmm
wake people up.
Right.
I don't know that I buy that. It may be in
Wow.
some, okay, but the only way to know is to have the data and have them hooked up and evaluate all these things for a period of time, not just one night.
Yeah.
Who's going to do that?
hmm
Right.
But to answer the second part of your question is like, am I ordering PSGs and doing pre and post? I'm not.
Okay.
But Prafula Thumadi, who is in India, and he was trained by Robert, and he validates a lot of the stuff that I do and a lot of the stuff that Robert does.
What's his name? Can you say it
And
again, Dr. Sutter?
Prafula Thumadi.
Okay.
Last name is Thumati. And if you didn't catch it and you go on to ResearchGate, you'll see he and I published together. But one of the things that he is doing is a cone beam study, and he's doing a volumetric analysis
Oh.
pre
Ah,
and post.
nice.
So this is probably going to take a few years,
Yeah.
but I kind of found something that I thought was interesting, but I found it incidentally. I had a lady that I was treating, and she was a speech pathologist, and she had some degeneration in one joint, and she had bilateral joint surgery like in her 30s, and she's now in her 70s, right?
hmm
And I'm treating her, and I said, your joints don't really look that great. We're having the conversation.
Right.
Like, you need to be made aware. If you want to do this, your joints are not great. And she's like, yeah, well, I didn't think they would be. They weren't great when I was in my 30s, but let's still try it. So patient's been made aware. We do it. And so she feels better, and her symptoms start to really come around. And she was a cervical dystonia. was her official
Oh, wow.
diagnosis, because her neck would go to the right
Mhm.
and up. Okay, so that movement alone is going to probably constrict the way, the air, the lumen of the trachea is, and restrict it. So I'm talking to her and I said, every 2 years, I want to take a cone beam so I can see what that joint's doing. And she's like, yeah, that's fine. I don't care. So I have, over a 6 year period, I have 3 different cone beams of her. And she had a cyst in one condyle. And, conventional wisdom would say this is not the case to be adjusting occlusion. And she's like, yeah, well, I'm giving you consent and I want it done. Okay.
Just do
So
it.
we do it. And I'm like, well, I want to follow up with you. And so what happens is that year 2 after DTR, we take a cone beam and I'm like, the cyst is gone. We can't find it. And so I send it over to beam readers and I'm like, I don't tell them anything. I just tell them, hey, I'm seeing something in the left condyle that I'm not seeing 2 years later. What's going on? So an oral maxillofacial radiologist gives me a report and says, nascent bone has grown in this area that was void. And so,
Wow.
well, how do you explain that? And Marcelo Matos down
What?
in Brazil,
Yeah.
his therapies are doing the same thing, right? And so I think what's going on is when you depress the inflammatory markers in the body
Yes.
is allowed to heal in ways that it can't when the inflammatory markers are high. Okay. So anyway, I call this radiologist up and I'm like, hey, there's something extra in your report. And she goes, oh yeah, you're talking about airway. And I'm like, yeah, what's going on with that? And so she says something like, yeah, the airway volume increased like 70%, something
Wow.
ridiculous. The volume was ridiculous. And the only thing I could think of, and this, by the way, this is published in the book chapter. If you have the book and you go to chapter 18, you can read all about this case, and you'll see the volumetrics diagrams side by side, pre-DTR, post-DTR. And so I sent this to Robert, and I'm like, this is really interesting. He's like, yeah, we should do a study. And I'm like, dude, I'm not doing another study. Like, I've got so many things that I'm interested in already. Have somebody else do this. And so Profula's like, I'll do it.
Yeah.
So that's where that's going. And again, I think part of that constriction was her actual diagnosis. Would I expect that in every single person? Probably not. But I think it goes because we hear that feedback so often about improved sleep. I think
Yeah.
it goes with patients being able to get into a comfortable position faster
Yes.
when they get into bed versus like, I can only sleep on the right side. I can't sleep on the left. Or the worst ones where I sleep in my husband's captain's chair because I can't lay flat. Right.
Yeah.
Well, what about patient that has like a tongue habit or has with that moved their anterior teeth? Can you also treat them with DTR? And like, does myofunctional therapy come into play with these people?
I think it could. If you're talking about like a tongue thrust and you said anterior teeth had moved, which would make them more like a class 2. And so I think we've already addressed
Yeah.
that portion of it.
But with an open
And
bite. Like,
Open bite,
because
yeah.
a lot of,
yeah,
yeah.
with an open bite, I'm building an orthotic to give them some quick relief. And then once they're stable and they feel better, we can talk about how we can correct that either restoratively or orthodontically or some combination of two, right?
Wow, Ben,
I know.
thank you so much for joining us. It's just mind blowing, and you know, this episode I think on Unclenched is really really good, and you have given us so much to think about in sharing your knowledge with us. We so appreciate it, and
Yes.
we're very grateful for that.
Yes.
Well, I appreciate the opportunity, and sorry if I went off on a tangent, but I'm
Oh,
trying
no,
to,
it's fine.
we're educators and we're trying to get
Yeah.
more people to just kind of wrap their head around something that's different but is measured.
Right, right.
Yeah, totally,
So,
and, I mean, we really appreciate it. I've learned so much. I'm ready to drive down to Eugene right now, so watch out. No, just kidding. I
all right,
I'm, like,
well,
half
let's
joking.
if you're
Yeah,
yeah, yeah. Well, if you want to if there's a couple of courses that are coming
Yeah,
up
yeah.
where I'm going to be lecturing and
Sure.
where I'm going to be at ICMO coming
I
up.
know.
Yay!
Um,
We'll be there.
and so
We'll be there.
I'm there for 2 hours, but there's a 2-day course that's coming up actually next weekend in Vegas, and
Very
then
good. Okay.
I think in September there's another one.
Right.
Awesome. Well, let's go ahead and answer a couple of questions from our listeners. So let's go
Sure.
for that first question. My ENT told me that my ear ringing is TMJ and my ears are fine. Another ENT told me I have Meniere's disease and there's nothing he can do. Can you help me understand what is happening?
Sure. Well, there's a couple. That's a lot to unpack.
I know.
So we know that TMD has fullness in the ear complaints, tinnitus complaints, vertigo complaints, dizziness, hearing loss, and Meniere's disease has those same things. The difference in the diagnosis is going to be who does the diagnosis. So if you go to an ENT and they do an MRI typically to rule out an auditory neuroma, and everything else looks clear, like there's no fluid in the ear, there's no redness in the ear, there's no infection, there's no pus, you're going to get labeled with Meniere's disease. And sorry that you got labeled with that, but then a lot of people aren't even going to want to touch you, right? And so in my office, I don't care what the diagnosis is. I really don't. We're responsible for the occlusion. And if the occlusion is off, you need to correct it, right? So you can put an orthotic in first and see if the patient gets better. And then on a second, therapy, do DTR. But the big thing is, regardless if a tooth has got 35% of total bite force on it, and you don't do anything, that tooth's going to break. It's going to have recession. You're going to need a root canal. You may lose the tooth. You may need a crown. So, like we we've we have abdicated our responsibility on what occlusion is because no one's measuring. And I think that allows medicine to see a lot of these patients that are really ours, and they can't fix them. So they come up and they say, well, there's a classification, right? So Meniere's saw this, and first of all, 1861, right? So we haven't changed the paradigm at all in 150 years. So, and if you go and look at cadaver studies for Meniere's disease to find some abnormal composition of fluid that would be in the inner ear, there aren't any. Like, really? 150 years, you guys haven't even seen if there's an abnormal amount of calcium or some kind of electrolyte or something that's throwing this off. And even if you did, it's still not going to explain ear fullness. It's not going to explain ringing in the ear. It might explain some of the vertigo, but there's a triad before you get that diagnosis. And we have to be careful when we are diagnosing patients with a diagnosis that's just clinical observations, right? There's no test that you could do.
Yeah.
Yeah.
Well, and a lot of people too have like that stabbing pain, like, ooh, right in
Mhm.
the ear.
Yeah.
That's you feel bad for those because
Oh,
they're
I
just like
know.
mentally beat, and it's just there.
I just spoke to someone who has that all
Yeah.
day, every day, and it, like,
Yeah.
goes from, like, a 3 out of 10 to a 10 out of 10, and she's just, like she's at her wit's end.
Yeah. Yeah.
Yeah.
So there's another question too that we'll answer. Eh, we get these answers from our listeners, so keep them coming, or these questions from our listeners, so keep them coming. How does TMJ make teeth sensitive, and will that go away? that to me all leads to Ben and the bite and the forces down the tooth, and then the periodontal ligament absorbing those forces and the sensation. So once you do balance out a bite with an orthotic or with the DTR, that sensitivity, I see it multiple all the time go away, really. Unless there's cracked tooth or something that's a little bit deeper. How
Yeah,
about you?
something.
Yeah.
Yeah, I see that go away really fast, and I still remember the when I started working with Dr. Parker, my mentor, and a patient came in. I was just shadowing at the time. I was really just fresh to this, and she said, "Well, I had a root canal on this tooth, and it's still just bothering me. It's like aching all the time." And Dr. Parker was like, "Yeah, yeah, we can take care of that." And I was looking at him. I was like, "We can? Like, doesn't the
Yeah.
root canal need to be redone? Doesn't the tooth need to come out?" I was like, "Okay, well, let's see how this goes." And yeah, I mean, right after she got her orthotic, it was gone. And she was blown away. I was blown away. I was like,
Yeah, sure.
wow, this is amazing.
Sure. Yeah.
Yeah. And tooth sensitivity is a multi-billion dollar industry in this country,
Right?
right?
Yeah. Yeah.
Truly, truly. Well, yeah, well, we just want to thank you, Dr. Ben Sutter, again for joining us. I learned a ton. I sincerely hope our listeners, viewers, whatever, learned a lot too. I know that I'm gonna poke you. I'm looking forward to seeing you at ICMO, all the things.
Yeah.
Yeah.
So
Yeah.
so the ICMO meeting in Denver, Ben will be speaking and he has other engagements. So look him up on Facebook, or he always has some excellent testimonials. So if there's any dentist out there that would like to learn more, please come to ICMO, message me, Priya, Ben, and we'd love to meet you and go from there.
Yeah.
Thanks,
Well, thank you
Ben.
for having me, guys.
Oh,
All
love
right. You guys
you.
have a
Love
good
you.
weekend.
Love you.
Thank you.
Have a good weekend.
All right, guys.
Bye, everyone.
Bye bye.